Hello again, Professor Harris.
Good afternoon.
My lady, may Professor Dame Jenny Harries be sworn, please?
I do solemnly, sincerely and truly declare and affirm that the evidence I shall give shall be the truth, the whole truth and nothing but the truth.
Professor, your full name, please.
Jennifer Margaret Harries.
Not your first time here, we all know. But I do have a number of questions to ask you, in particular about the adult social care sector. And for those who are perhaps not familiar with this model, or indeed the evidence you've previously given, you are, I think, still the Chief Executive of the UK HSA.
No, so I retired at the end of May, so I'm here in my own right and no longer a senior civil servant.
Thank you very much for correcting us. You were the Deputy Chief Medical Officer for England from the 15th of July 2019 to the 31st of March 2021. Yes. And it's in that capacity that we have asked you on behalf of M6 to provide a witness statement. So my questions are going to be focused on your role as the DCMO, as it's colloquially known. You set out your professional background in your statement. You are a clinical doctor with specialist training in public health medicine. You hold a number of different degrees and qualifications, but perhaps pertinently to your role and indeed your role in social care, before your appointment as DCMO, you were the Regional Director for the South of England within PHE from 2013 to 2019. Is that correct?
Yes.
You had also, before that, I think, worked as a Director of Public Health.
Yes.
In both Norfolk and Waveney, Swindon and indeed Monmouthshire.
Yes.
And can you just help us? Is there anything particular in your former role as a Director of Public Health which has helped you with your advice that you gave in the pandemic?
Yes, definitely. In fact, the reason I ever came into the centre of government was because I would sit as a Director of Public Health and think, how is this guidance or this plan or policy going to work here? And it was actually to try and ensure that the voice of local, if you like, was imparted to national decision makers, which was generally very well received. So it's been it's good, but it means that the working, for example, as a chief officer in a local authority, you work alongside the Director of Adult Social Services. In some local authorities, the Director of Public Health actually is the Director of Adult Social Services and will oversee them, and vice versa.
You had been involved in a number of UK public health responses and health protection incidents. And indeed, your previous roles in hospital health boards and in local authorities, you say, afforded me experience of both health and care services.
Yes.
Their commissioning and their delivery, and indeed the functions of local councils. A couple of things on that before we descend to some detail. In your role as the Director of Public Health in Wales in Monmouthshire, was there anything particular about your experience there that might have meant there are particular vulnerabilities in the Welsh adult social care sector that you're able to speak to?
So it's a little bit difficult because I think the time period from when I was working in Wales, my most recent posts have been in England, so I think that would probably not be appropriate to comment. Right. I can comment on data in due course in relation to work that I've done recently.
Thank you. Throughout your time as DCMO, did you get any sense of whether there were other people that you were working on alongside who had both the kind of hospital or healthcare aspect within their knowledge and the social care, or were you quite a sort of rarity, if I may put it like that?
There are people, and when we talk about the Department of Health, obviously there are organisations aligned to that. So in the start of the pandemic, Public Health England, for example, and some of the people working in UK HSA now are ex-directors of public health, so they have quite a lot of knowledge from the ground in the same way that I did. But equally, the standard civil service model is that somebody moves around a department and they tend to, not always, because people come with different skills, they tend to move between departments to get experience of that department's function and role. And I suppose the point to raise is I was quite surprised. My DCMO role was the first where I had actually worked directly in government, in the centre of government, and I was quite surprised at how focused. The Department of Health was at the time at the start of the pandemic, on health and NHS and clinical topics in comparison to adult social care. I know that's a topic, and I think that is a point that I found.
All right, we're going to come perhaps and look at some examples of the focus being on perhaps the healthcare side as opposed to the social care side. Before we do, though, you summarise the Deputy Chief Medical Officer's role as primarily being one to provide advice.
Yes.
Often at short notice.
Yes.
And working with tight deadlines. And I think throughout the pandemic, you had engagement with both Mr Hancock and indeed Helen Whately, the Minister.
Yes.
You also had engagement, you say in your statement, with directors of public health. And I'm at your paragraph 3.7, Professor, little 5, if it helps you. And you said you actively linked with directors of public health, many of whom you had worked with, presumably in some of your previous roles. In what way did that assist you in advising as DCMO?
It's always good to have two-way flows of information. I would like to check if somebody said, this is what the Directors of Public Health think. It's always good to check with the Directors of Public Health that that is what they do think. I had a number of them who would provide information, almost what I would say, what's the real picture on the ground? And I would speak to some of them in different parts of the UK, because clearly the pandemic hit different places in different ways and the infrastructures were different. I think the key thing that I did at the start, bearing in mind that the CMO was relatively new into that role as well, was to encourage the establishment of a CMO to Directors of Public Health meeting, which continues to this day, but was not in place routinely prior to that. If the CMO wasn't there, I would chair that meeting, and it acted, I felt, as a conduit and a professional airing space, if you like, so that Directors of Public Health could hear directly from the centre on professional issues, but also raise some of those issues back.
May I ask you then, please, about an email? Could we have it on screen, please? INQ 151538. It's an email exchange including you, Professor, from the 6th of March 2020, so relatively early on. And if I could just help cite you, perhaps on page 3 there, thank you very much. There was work underway about a meeting that we're going to come on to look at the minutes of, involving... the work's underway including Public Health England, NHSE and I. DHSE issues include identifying the categories and identifying the individuals, the model for those in domiciliary care, mental health and avoiding isolation. Are you able to help now with what was being referred to as the model for those in domiciliary care?
So this is now a very long time ago, and it's quite difficult to remember the detail. I don't remember the detail of a model. What I see in this email is me in that advisory role. What I also tried to do was connect people across the system. So it usually wasn't my role to do things, but if I was aware somebody was considering something, to make sure they were aligned and not duplicating. So it probably just refers to developing guidance effectively, I would think.
All right. And if we go to the bottom of page 1, and I'm afraid the email continues into page 2. So thank you very much. This is an email at the top of the page from you. You've thanked the recipient. Definitely needs to come back through CMO's office. A key point on this, both for safe management of patient, but also links to imminent potential messages on communities, is to clearly identify and show we've identified the linkage into local authorities and directors of public health. I am quietly working very hard to keep all 152 of the latter behind CMO, so they can be a sensible extended arm of the scientific message in top tier and unitary councils. Now, you may have sort of alluded to this in your early answers, but what was the quiet work that you were undertaking, and why was that necessary?
Well, it was basically to ensure that Directors of Public Health are really important. They will be the CMOs, if you like, of their local authorities. And they know how the top of the system works as well as the local system, whereas some parts of national won't, and vice versa. And so actually working with them so that they understood why decisions were being made on what scientific evidence meant they could act as a conduit of good evidence-based intervention back to their local authorities. So it's not so much that there's always a risk that people will go in different directions if you leave an information space. And it was really to do that. And so the meeting that I referred to was one of those. What this is actually doing is flagging politely, will you please remember directors of public health and local authorities?
Why do you think people might, or the department might have needed that polite reminder?
For the reasons which I started with, which is most of the department's work, for very good reasons, was highly focused on the health side and often on political imperatives, waiting lists. We only need to think what people see on the front of the pages. But I think there's an important point here as well, which is, as I think many witnesses have said before, the department did not actually have control over local authorities or directors of public health. So the sort of standard civil service expectation generally is that you put something up one department, you take the message across, and then it goes down the other department's side. But where you have a professional direct linkage, I felt that it was one that needed to be used, particularly right at the start of a global pandemic.
Well, you make the observation in your statement, Professor, that there was no dedicated team in place at the start for the adult social care response. And if it helps you, there was a meeting on the 11th of February 2020 where you make the observation there was no substantive dedicated G6 role, that's a role below a deputy director, or team in place for the adult social care response. I'm not suggesting it was your responsibility, but do you know or have any sense of why there wasn't a team already in place for dealing with adult social care?
So I think I was asked to comment on a paper, so just on an email. So just for clarity, there clearly were people working on adult social care. I would not like the chair to think that there were no resources. But when it came to a sort of emergency response like this, it's very clear from the chain that sort of capacity was not there, whereas if you looked at the health side, there were immediately people to identify, to respond or prioritise their existing work.
And you say there that indeed at that meeting, we don't need to look at it, but there was a number of slides that were put up at that meeting which mentioned social care only briefly. The predominant focus at that point was on healthcare. Now, one can understand the need to look at the healthcare aspect, but did it mean that there was less people saying, but what about the implications of this on social care? How did it actually play out without having that expertise and that knowledge?
So again, this is difficult because it's a long time ago. My sense actually was that the ministers, so the Secretary of State and the Minister, were very observant and on to what needed. Actually, because there wasn't so much of a routine cadre of officials working to this in the same way or the same intensity routinely on the health side, that there wasn't, there wasn't a group to turn to. Usually, if you're challenged to do something, you find the group nearest to that topic, that policy topic. And actually, what happened here was there was a recognition that more staff and more resource was needed, hence the comments about appointments. But there wasn't an existing team there to bulk up, if you like.
Did that not hamper the response, though, if you haven't got that team to turn to? That's what I'm...
Well, I think, going back to the point about understanding, and this comes through, and perhaps why you will see my name appearing more frequently at the start, and then I sort of drop back more to my usual role, was and it could be a personal perception, I sensed that officials often did not appreciate how care systems worked, how they were commissioned, what the data flows were or not, as we might come on to. And therefore, there's a risk of not engaging the right people to take that forward. Now, again, this changed dramatically through the first few months, but this is what I felt was the existing position. It wasn't just for social care, though. I think this issue about the departmental. So there was an incident very early on around declaring a major incident in the Wirral when passengers were coming back, where I personally, I volunteered and said, well, shall I ring the chief executive and see if we can avert this? Because it didn't feel necessary to me. What I realised was people, they understood the theory of the emergency response. They didn't quite realise why the chief executive in the Wirral, who was totally responsive, would be worried and how they could help. So it's this kind of lack of tangible understanding of how people would feel if they were sitting in a local authority or a care home or wherever it might be. And that was the national-local disconnect.
Disconnect was going to be the word I used. Understood. Thank you, Professor. I think in a number of places, though, in your statement, you make the observation there was limited understanding in the department about adult social care generally. Other people might put it as adult social care being an afterthought. Is that something you would agree with or not? And I see you put a face there.
So that's quite a pejorative statement. I think what I would say is departments tend to be driven by political imperatives. They have to reasonably respond to the requests of ministers. And as I say, I wouldn't like to suggest this was an issue of individuals at that time. The fact is, which we might come back to at the end, there is a wider imbalance historically between the attention that has been paid to the National Health Service and the attention that has been paid perhaps even to community services in comparison to hospital services, but certainly into care services. And to my mind, they are very, very firmly linked and should be on a continuum.
Can we go to the meeting, please, of excuse me, of the 11th of February of 2020? And could I have up on screen, please, INQ 4049363. It's an adult social care coronavirus meeting. We can see that you are present along with a number of other names that we are familiar with. And Ros Rawson stated there's a tripartite plan to dealing with coronavirus and social care. One, raising awareness in the sector to promote prevention. I know it's difficult now looking back 5 years ago, but raising awareness about what, or what particular aspect of COVID-19 needed raising awareness in February 2020?
I honestly can't remember. I would be guessing, I'm afraid.
All right. There was a plan to deal with preparing for the reasonable worst case planning assumptions and then putting in place the appropriate staffing and resourcing. And in fact, Professor, we know that from DHSE that the team exponentially increased over this period of time. But could we go to second page? And action 1, the adult social care team is to work with David L to draft clear lines on who has responsibility for response, noting the secretary's steer that primary planning responsibility is for local authorities ahead of the planned publication of the COVID plan. Chris Wormold noticed this should be framed in the context of how we will support planning nationally. Did you agree or have any observations to input into the clear lines of responsibility lying with local authorities?
I mean, yeah, I can talk to the action below, which is to my name, but in a meeting like this, I would be there. I would put in comments and have them always listened to and challenged or accepted as appropriate. I don't remember anything particular about this.
All right. If we go to the action that involves you, I think it's in paragraph 6 and action 3. There is a need to provide some clinical advice to cover what should happen when there is a case in a care home, to include advice on isolation, delay of transfer of care out of hospital, moving patients. This should include an assessment of the practicalities of each option. So we'll require input from the chief social worker, and the ASE team.
Yep.
And it says DCMO to draft clinical advice in response to a case in a care home ASAP, likely to require input from those. So this is in February, pre the hospital discharge policy, but can you help us with what was being discussed here and why DCMO was being asked to draft clinical advice?
Well, she shouldn't have been. In fact, I think there is a subsequent email afterwards where I politely say this is not what I would normally do, and this is usually a role for Public Health England, but obviously try and align things. Actually, at this time, COVID was a high-consequence infectious disease, so in fact it would have been very clear what would happen and was already in guidance, which is any case would not be managed in a care home. So there's a slight, and I think when I responded, it was all along those lines. There are 2 points. One is what would happen now, and then there is a longer-term, wider issue about planning for cases when there are a number of cases across the country.
Bullet point 8, JH noted there are some difficulties around informal carers. Do you mean that unpaid carers?
Yes, I mean, basically, I think I was highlighting, just to reinforce, that not all care happens in hospitals and not all social care happens in care homes, and there were a large number of other care recipients who needed to be considered.
Yeah. So you're noting there the difficulties around how unpaid carers and domiciliary care in particular, around how isolation would work in those particular settings, and lack of information flow between private sector providers and the local resilience forums, and what the triggers would be in a reasonable worst case scenario. Can I break those down, Professor? The lack of information flow between the private sector providers and the LRFs. Do you know what was being spoken about there?
So again, this goes back to did people understand? So as I know you've heard many times before, adult social care is effectively a large private sector model. Now if you're thinking of it in people's well-being and health, that can sometimes be a tricky way of thinking, and it doesn't feel very person-focused, but that is the reality of the provision model which has been in this country for decades. And so when I'm talking there about private sector care providers, these are all individual providers of different sizes or potentially chains, most of whom will have contracts with local authorities, and the local authorities will have data, but they will not necessarily have data which is relevant to this. So they might have contract data, how many people have gone through and have they paid the right things. But actually what you want to know here are all the things that you have been asking questions before. The other point here is that it mentions LRFs, and in the early discussions, I think there was a sense that the local resilience forum would be the focus of control, support and distribution, and they did play a really critical part in things like testing and some PPE distribution. But, and again, I think there is an email. The problem with the LRF, so I used to go to LRFs as a chair on STAC, so a scientific group, but also on occasion my chief executive in Swindon, for example, would delegate the role to me. So I would go as the chief executive of the local authority. And people essentially did not seem to understand that the LRF was just made up of people who did their jobs routinely and then came to the LRF on top of it, so that they didn't have a routine system usually of receiving data. They would work together to make their routine data streams beneficial for an incident. So it was really trying to highlight some of those issues.
You, picking up on that answer, you say in your paragraph 5.12 that in the early phase of the pandemic, few people in DHSE had direct or practical experience of having worked in or with care homes, the commissioning of care home services, and understanding the local connections which would underpin the ASC emergency response. And so is this perhaps an example of they didn't really understand how the LRFs worked, and not the limitations of them, but just how they weren't geared up for a
I felt there was
response?
an over-expectation, because if you look into a pandemic approaching, every single senior representative, whether it be the police or the chief executive from the hospital or the chief executive of the local authority, has already got all of their work cut out. And so to expect, the group would work well together, I'm sure, but there was no extra resource. It was a potential of double counting was how I was trying to warn people not to rely too much on it, I think. It's not a body in itself, I think that, and it doesn't have an exit. It has a very small funding stream, but it's not another big organisation that you're suddenly going to pull in to respond in a pandemic.
You said that in your view, lack of data, which we'll come on to, and the limited understanding of how the ASC sector practically operated meant the ASC response required considerable and urgent efforts in that early period.
Yes.
Are we talking February, March,
Yes.
April?
Yes. I mean, I think this, wherever it was, this meeting, and then I think there was another one at the start of March.
Yes.
Where it was absolutely recognised by ministers that there was a lot of work to do, and then things really moved.
As at February 2020, and in the lead up to the expedited discharge from hospitals policy, I think you said in your statement that you contacted colleagues at NHS England and PHE to request further information on their pandemic preparations and how they would interact with the adult social care sector. You say, I was concerned that the two would be developed in isolation, given the usual higher focus on acute hospital care. Can you just help us with, if you're able to give us a little bit more detail about why there were potentially being plans developed in isolation, given that if there were expedited discharges, inevitably some of those discharges would result in people being discharged to the adult social care sector?
So I will be moderately outspoken at this point. The routine thing is that the health, having worked in local authorities, the health service tends to be quite, the hospital service, I will say, tends to be quite dominant historically. And therefore, actually, the system would tend to work from the hospital health service side. I think PHE colleagues who are linked into the health they have their own health protection teams in the regions, were very used to working on outbreaks and with colleagues in care settings or with local authorities. But there's always been a natural sort of divide somehow between, I'd say this on a long career as I leave it now, between the health side and the community elements. And so what tends to happen is everybody goes off to do their work, which is entirely right because they all have different skills. But then the trick is not allowing the two bits to develop independently too far, because you then can't join them together successfully, and you tend to end up with disparate messaging and slightly incoherent messaging as well.
In your statement at your paragraph 5.19, you said it was clear to you from both the technical public health knowledge and practical experience of work in the hospital sector that demand on hospitals would rise rapidly. Understood. And that in the event of a severe COVID wave, there would be a foreseeable need to free up capacity by discharging of patients. And you said to this extent, it was something which was always known to be a realistic possibility as soon as it became apparent that COVID was on the increase. But was it realistic to the ASC sector? Do you think they could see, or were they ever told, it is really likely, as at February into March, before the actual letters went out from NHS England, that discharges were coming?
I'm going to state the obvious, which is probably that's a question to ask the ASC sector. There is, going back to previous planning, clearly there is an expectation through flu planning, for example, or whatever the issue might be, that if cases rise in one part of the system, people need to move. But there are other reasons for doing that as well, which we might come on to, which is you do not want elderly, frail people sitting in a hospital waiting for a rising tide of cases. So whether the adult social care sector either had been advised or had absorbed, because I think they're also quite different things. I think lots of people realised why theoretical plans that had been discussed over many, many years had been discussed when they were hit with the reality of a pandemic.
Did you ever get any feedback, given that you had sort of a number of contacts from your previous roles, a sense of it was a surprise to them that there was going to be an expedited discharge policy?
I don't think I can comment on that. What I can comment on, though, is from feedback which I did include, for example, from Directors of Public Health, which is probably my more direct link into some of the conversations at the time, was that actually even the LRFs were standing up there. We could see a big pandemic coming, even the LRS were not standing up their strategic coordination groups uniformly across the country. So that, to me, meant some people had logged the enormity of the task ahead, and others had not quite done it.
Your statement sets out, and I'm not going to go through it all, the rationale and the reasons for potentially why an expedited discharge policy is required. But you do say this. You say, lastly, I did not consider it inherently an unreasonable ask of the adult social care sector to isolate infectious cases. Can you help, from your perspective as DCMO, why you didn't consider that to be an unreasonable ask?
Because actually, basically, I recognise this as a novel disease, but basically the asks of isolation and the hierarchies of control around IPC are the same that you would apply for any respiratory infectious disease. And so I think PHE guidance on flu had been updated in 2018. All of the isolation requirements and risk assessments were there. And care homes did link with and would report outbreaks into health protection teams and to CQC. I mean, there is a wider issue as to, if you like, how far the country has questioned the capabilities and capacity for care homes to do that and what levels have been accepted historically. But based on what had been accepted routinely, then yes, there was a reasonable expectation, I think. I think also, again, we might come to this, in that guidance also, it has never been the expectation that if a care home cannot isolate effectively, that there was always, it wasn't a requirement to accept, it was a requirement to put your hand up and say, actually, we can't do this.
Please say if this is an unfair question, Professor, but did you get any sense as DCMOs whether those that you were advising understood that there may be care homes that couldn't isolate?
I think I can't answer that. I mean, even this is where the national local comes in, because if I, for example, went to an individual consultant in disease control at one of the now UKHSA health protection teams, they would know probably which of their care homes were better able to do that or not, because it is so dependent on things like building size, whether there's sufficient staffing, how good the IPC training is, a whole host of things. And so it's very difficult to say that. What you can say is it would be variable across the country. And I think at national level, people would understand that.
Some of the guidance, and you've set it out in your statement, you are cited upon and asked to advise upon, but not necessarily every single piece of guidance that came out. But can I just ask you about this? The 13th of March guidance advised that a care home should implement what they called isolation precautions when someone displayed symptoms. By the 2nd of April, it said explicitly symptomatic people should be isolated. And by the 15th of April, it said isolate whether they're symptomatic or asymptomatic. So it varied across that 6 weeks or so period. From your perspective as DCMO, do you think that variation was a reasonable response, or should it have said from the get-go, isolate everyone?
So this will go back to discussing what was known about asymptomatic infection and completely separately asymptomatic transmission over that time period. And we may well come on to some of the studies, because that time period was actually quite critical. It was, I'm trying to remember my dates now, but at the point that lockdown was called, which is right in the middle of that, the preceding week, the testing was prioritised, actually identified what level of community transmission there was by increasing the testing of those patients coming in and effectively extrapolating backwards. We then had exactly the same. We had started to have initially sort of rumblings of reports from the US, for example, on long-term care facilities, and then over the Easter period, so they're all starting to come together, were the first proper UK studies, and they got stronger. So there was a sort of initial test. How many people have we got here? Then we had a period prevalence study. Then we've had cohort studies. So this is a rising tide of information, and coming through that period. And I think it's right that the guidance changed. I think the differentiation is right in a progressive term. One can look back and start to query precisely on which date which person knew which piece of information and whether the timing was right. It feels about right to me. I think we also need to remember it's hugely difficult to get practical information out. So, for example, if the NHS or PHE was publishing guidance, it would need to be gridded on the national slot, so it aligned with political announcements of changes. And that's very difficult. So you can have guidance ready or almost ready or whizzing around the system or being signed off by different ministers in different departments and then going out.
I jumped ahead a little. I just want to ask a few questions about pre-pandemic planning to the extent that you can help as DCMO. And could I have up on screen, please, INQ 000151 466. It's back on, it's actually Valentine's Day, 2020. It's an email from you to a number of people in NHS England. And you said to Keith Willits, the Secretary of State is entirely appropriately becoming very focused on the ASC planning in, is that reasonable worst case scenario?
Yes.
You may remember, be aware, this was a significant weak interface when we exercised Operation Cygnus. And are you able to briefly explain to us what was the weak interface?
Well, largely that, I have checked back on what the objective of Operation Cygnus was, and I won't get the terminology quite right, but the objective actually was around looking at the policy implications of a pandemic rather than actually the operational side. So I may be slightly moving ahead, but obviously if you haven't got clarity on the policy, you clearly won't have clarity on the operational side. And so what I was signalling here was this wasn't very well defined when that was exercised before. So can we try and do something now ahead of it and stay together, which again, this is the whole point about if you can see there's going to be high demand in health services and care services, making sure that the messaging and the actions are all aligned.
Well, can we come on to one of the meetings that perhaps looks at a little bit more of the potential planning and the coronavirus and social care meeting on the 6th of March 2020. And can we have up on screen 4049530, page 1 in the first instance. And Professor, you were present at that meeting along with Mr. Hancock. I think Chris Wormold was there, Helen Whately was there. You can see other names with which we are now familiar. And the Secretary opened the meeting by stating the impact of corona has posed a complicated set of problems and essentially calling it, in his phrase, needing to be gripped. And Helen Whately noted we needed to ramp up preparedness around social care. Now, as DCMO, did you have any role in preparedness for social care, or were you simply just advising on plans if they were brought to your attention?
So there was a social care department, if you like, group. I wasn't part of that. Obviously, I would be called in to advise as appropriate on anything that they felt I could.
You had noted in that meeting reference to the Washington State study in nursing homes where there was a mortality rate of 30% in that study. Now, in fact, the study didn't come on to publish various other results until the end of the month, but you'd obviously got sight of an early.
So, I mean, we always are looking across the world and linking with other professionals to try and get early insight, but it's important when you do that, that actually the final publication or final data is there, or you sometimes get misinformation. But in this case, I think it was around 27.2% for residents. But noting as well, which I think Ros did, that this was a long-term care facility in the US, and the demographic and the health status of those in it may well be different. So this was a signal that says, in exactly the same way that the Secretary of State and Minister for Care had said was, we need to really be looking at this. It doesn't necessarily say that's what would happen in the UK.
I follow that, but this is a warning shot, if I can put it like that, of potentially significant numbers of mortality.
Starting to be early feed coming in.
All right, so this is us at the 6th of March, and then if we scroll down the page a little bit, we can see there Chris Wormold's asking for more data about the reasons why people are staying in care homes. And then the next bullet point, you flagged that the majority of people that we're talking about are receiving domiciliary care too. Secretary of State agreed that we should be thinking about this in the following hierarchy: residential homes, nursing homes, and domiciliary care. Can I break down the constituent parts of that, please? You were flagging the majority of people that are receiving domiciliary care. Why did you need to bring that up in this meeting?
So I would I've gone back to look at this minute. I don't think this is a well-expressed minute. Let's put it that way. Might have been because of the urgency. So I think what that sentence was saying, I was flagging that actually the numbers in domiciliary care were enormous, more so than in care. There are different risks to it, but it was just to make sure that we got the proportionality of approach across the whole of the sector, and we didn't only focus on care homes.
All right. Can you help at all with the next sentence, which says the Secretary of State agreed we should be thinking about this in the following hierarchy? Do you know what the "this" was referring to?
My sense is it was actually what we needed to do, so a very general one, but again, it's a long time ago. I'm sure your next question will be on the word hierarchy.
It is.
And I have reflected on this because, for two things, which is what made me look at the rest of the email, because there's some very strange expressions in this email. For example, somewhere further down, I think it talks about excessive deaths, whereas in fact it should be excess deaths. So I'm not reading a lot into the word hierarchy. I think whoever was doing the minute was probably quite new at the minutes. I'm very comfortable that all of those groups were being actively considered and discussed.
Did you get any sense, though, that there was a priority being given to residential homes over nursing homes?
No, not between residential and nursing, no. I mean, the risks that were coming through, partly because the data were very much focused on residential and nursing, but that felt proportionate.
All right. Was there any, can you recall now whether...
Sorry, can I just add one thing
Yes.
to that? The only other differentiation which might come up is because actually in a nursing home, of course, there are theoretically, we might come back to, more there's more clinical capacity. And so when you're looking at a whole nation, trying to say where are you going to have respiratory care particularly, or step-down clinical facilities, then obviously a nursing home in theory should have more clinical capacity to address that. So that might be another differentiation. But that's not the order, of course, in which they're described here. I think that, to my mind, that's probably just a red herring.
Right, all right, thank you. Down the page, you updated the meeting on your call with the Directors of Public Health. I think we've discussed that. Can I go over the page, please, to the second bullet point? The Secretary summarised a lot of work to be done across 10 different areas, and workforce, financial support, excess deaths, data, support for non-COVID illnesses, equipment, which included PPE, and LRF readiness and collaboration. Do you know how much, if at all now, IPC and isolation was discussed in this meeting?
I don't think that level of detail would have been discussed. Clearly PPE is mentioned, and that is sometimes people write that instead of IPC. That's a sort of shorthand. It clearly isn't the same thing. But I don't think the detail of isolation facilities would not have been. But bear in mind, this is quite a high-level meeting.
All right. And just a little bit further down, there is a bullet point starts, there was a discussion on how we stop carers making uninformed decisions and sending people to hospital unnecessarily. Do you know now what the reference to uninformed decision-making was about?
I don't, I'm afraid. I can't remember. I don't think it's associated. I can see my name at the next bit. I can explain the next sentence.
Well, can I come on to the next sentence?
I don't think they're necessarily linked, is my point.
So you don't think necessarily the sentences are linked, and in any event, you can't at this recall now what the reference to the uninformed decisions was.
No.
All right. The next sentence is DCMO-JH noted not all LRFs have SCGs, strategic coordination groups stood up at the moment. The local context is probably not playing through. Flagging local authorities are getting FOI, as in FOI requests, freedom of information requests on excessive deaths. This is having an impact on capacity. Can you help explain there what is going on in that sentence.
So I think, so take that as a separate bullet from
Yes.
DCMOJH, then I can explain it. So this goes back to the point I just made, which is that actually different parts of the country were not seeing the risk coming at the same intensity and understanding. So some of the LRFs were stood up and in active mode, planning avidly, but I had reports back, privately through Directors of Public Health that not all of them had were quite in that active phase yet. And then it's probably saying already that some of the questioning coming back into the local authorities was starting to have an impact on people's capacity to respond to things. So, which was an inevitable feature, I think, going through the pandemic.
And just finally on this meeting, a little bit lower down the page, you are flagging these are really vulnerable people. Were you talking about staff or
Both.
recipients of care? Both.
Both.
Right. You reiterated that these workers are low paid, they need protection, they receive pay, otherwise these may continue to work at risk.
Yeah.
Were you essentially saying there that you were worried that they might continue to work because if they didn't, they couldn't afford not to?
Clearly, the articulation is also a bit awry in that sentence as well, which makes me worried about the rest of it. But yes, that's effective. I mean, firstly, that the people being cared for were vulnerable people, but I think that was accepted. What was perhaps I felt needed reinforcing was the fact that the cadre of workers who were critical to this part of the service, actually, if they weren't able to isolate and have the right incentives, not only would they be an increased risk to themselves and others, but they would effectively have no incentive to stop working. They wouldn't be able to because they wouldn't have any pay coming in.
Thank you. That concludes all I wanted to ask about that particular note. We know that thereafter there was various guidance issued in mid-March and then early April and indeed in mid-April. Clearly the testing developed and the capacity for testing increased throughout that 6-week or so period. But can I ask you please about your paragraph 5.5 in your statement, and in particular your concern about the advice given to residents about isolation?
Yep.
Because you say you continue to advise up to the point of the 2nd of April, where working directly with PHE, I reviewed and advised on the isolation period in care homes, whether it should be required for 7 or 14 days. And perhaps if we could have up on screen your paragraph, it might help those following. Can we have up 587-394_0029? And you've set out there in italics what the agreed position was, which isn't entirely replicated in the 2nd of April guidance or indeed in the 15th of April guidance. But can you just help us now, standing back, Professor, why from your perspective was it so important that there were isolation periods written into the guidance?
Well, obviously, you needed an isolation period. We were writing that applied to the whole population if you tested positive. So, and that's good. It was good clinical practice. The issue here, as you've seen here, is we had an elderly and potentially frail group of individuals in a care home setting with high contacts, vulnerable group, and then the immunosenescence, so the decrease in effectiveness of your immune system as you age is also an important point. What I had flagged in just picking up, so I would be sent guidance quite frequently and I'd try and spot things, particularly to align them or to try and spot anything that was inaccurate. What I spotted was that in fact, PHE had written in a 14-day period of isolation, which was fine, but it actually wasn't consistent with what we were doing for the rest of the public. So the reason I queried it was, are we saying this is what we want to do? Or, are you advising something different for this group? Because actually, is that fair if you're advising a care worker that they need a 7-day isolation period after infection, and you're advising a 14-day period for an elderly person? Is that fair in equality? Is there a good rationale for advising something differently? What the rationale was, we need to protect this population, and the 14 days went in.
And on the 2nd of April guidance that came out advised that there should be isolation of symptomatic residents. It didn't say anything at that time about isolation of asymptomatic
So
admissions.
these are getting slightly confused, I think, because this, I think, relates to individuals who had tested positive and were running out their isolation period.
Okay.
So this will be, I know there's a separate issue, but this will be either when they are discharged well or to complete a period of isolation after they were positive, I think. But it's not clear in this chain, actually. And again, it's difficult 5 years later to be precise.
Right. So from your perspective, though, as DCMO, clearly you were cognisant of the need for there to be isolation periods for the symptomatic patient who was being discharged to a care home.
Or the well patient who'd been discharged to the care home.
Right.
And I felt that this longer period, we'll surely come on to this, but recognise that an extra 7 days of isolation can be quite disabling for all sorts of other reasons for an individual. But it's not just the individual, it was everybody else in the care home who had to be considered.
From your perspective, though, the need for isolation was blindingly obvious, if I may put it like that.
Yes.
And I think you said to M7 that one of the reasons for that was the test only told you that you were negative at any...
The focus on the test is really, I class it as an adjunct to an intervention. It's quite good to know. It might change people's behaviours in some ways. If you know somebody is absolutely positive, then it might actually pay more attention to them. But that shouldn't be the thing. The really important thing is the isolation, not the test.
Yeah, in fact, you said...
The test is good for clinical care. That's exactly why it's priority.
Yes, you said, I think in M7, it's an adjunct, but it's not the main intervention for keeping an individual safe. Now, given that is your view on this, do you think in advising the ministers you pressed home enough the need for there to be isolation written into the guidance? Particularly given we didn't even have testing, and testing's not the sole answer anyway.
So I've tried to go back over some of my emails. I don't know if we're coming on to this later, but in the 2nd of April guidance, I mean, often what would happen, I would see these, I would put comments in, and then I wouldn't necessarily see the final version. So the final version of the 2nd of April did not come past my desk, nor did some of the comments, but I had contributed, and in the feedback to the minister, who was Minister for Care, who was absolutely asking all the right questions. Do we want to do this? Should we be discharging patients with COVID into a care home? I had gone back and said that we should, there was an expectation for risk assessment to ensure that appropriate isolation facilities are available. That I don't think has somehow come into a last version.
In your statement around this time at paragraph 5.54, Professor, you make reference to on the 1st of April, you and others provided comments to the Department of Health on a Dear Colleagues letter that was being drafted to go from the Secretary to MPs to update them on the response. The content was centred on acute health sector, and you flagged both the admission in the draft and the critical importance of ensuring the care sector care staff and critically of their work to the response was recognised in the correspondence. And I just want to ask you about why now in April? You've been flagging now for a while, if I may say, the need for the care sector to be considered. You've been trying to raise its profile, ensure that people are aware of the diverse needs of that sector. Can you help with why perhaps that message hadn't landed and you needed to rephrase the Dear Colleagues letter?
So I will preface this. There were some very, very brilliant people working in the social care team in the Department of Health, hugely hard, who did recognise this. But a bit like some other work on shielding, you can say things once or twice or 3 or 4 times, but you struggle to reach everybody in big departments and right across government as well. So, yes, you can see, I think I've got a few emails here where I start them by, I know I sound like a stuck record, but it was important, and people didn't get the tonation right at all. I used to think if I received this sitting in a care home, sitting with my dad, who I just commissioned services for, sitting as a director of public health, how would I feel about it? And often the language did not feel right. And I would usually try and comment on them, but clearly I wasn't seeing, it wasn't my job to be clearing every letter or saying things. Where I found them, I would comment.
One other topic, please, about your paragraph 5.63 and the extent to which the ingress of COVID into residential settings could have been foreseen and considered prior to April. And you say, perhaps if we could have it on screen, it might help those following. Could I have _34? Thank you very much. You were asked, Professor Harries, to what extent the ingress of COVID into care settings had been foreseen and considered. And you said it was logical that a virus which could be transmitted from person to person via the respiratory route was likely to ingress. What was not known was the extent to which the elderly would be disproportionately affected by COVID-19. May I ask you about that? Because we've heard a number of pieces of evidence to suggest that actually those living in care homes and in those settings were always more likely to be considered to be more vulnerable, to particularly respiratory illnesses. And I don't want anyone to misunderstand what you were saying there. Can you help with why it was phrased as what was not known initially was the extent to which the elderly would be disproportionately affected?
I think it's the proportionality of the risk. So yes, we would expect that. Yes, for the reasons of immunosenescence and the high contact environment, all of those things, those are long-standing risks for the future and need to be paid attention to. They are well known to a large degree because it happens with flu every year, and we might want to reset our expectations of how much flu we can prevent and what interventions we should take. But I do think here the startling difference in age, particularly as you get above the 75 to 80 one, this is not, I realise there will be sensitivities around age, but actually this is just a risk factor. It is a huge risk factor which was not predicted, I think, to the extent that it affected that group.
You say that whilst ASC settings would be expected to manage respiratory or gastrointestinal infections, IPC skills and capacity were probably weaker than in the NHS. In most geographies, specialist IPC skills and training capacity previously offered by some public health teams had decreased from a transition from public health from primary care trusts to local authorities. Even in residential nursing settings, the majority of care was provided by non-clinical staff. If that was recognised that there was a lack of training and skills around IPC, clearly that was another factor to be borne in mind at the time of the expedited discharge policy. Do you think people understood, the ministers that were making the decisions, that perhaps there was a weakness in the IPC skills in the sector?
So I think where I've put recognised, I recognised, many public health colleagues recognised. I'm not sure everybody recognised. And actually, even now, if you say IPC to most people, which is why I commented on the early letter, they think PPE.
Right.
And that is not what infection prevention and control is. And so there was definitely a loss. I know with my own move from having a public health team in a health primary care trust and moving it to a local authority, I worked very hard to retain two very experienced IPC nurses, but most teams were not that lucky, and most teams don't have them now. And I think, for others to confirm, that in the NHS now there has been a gradual tailing down of infection prevention control. I think it's now starting to pick up again because people realise how critical it is.
I understand that in the NHS, but just thinking about the adult social care sector, do you have any views, Professor, on who should be responsible for delivering IPC training in both in both pandemic and non-pandemic
times? So there's a formal and an informal answer. The reason I use my example, for example, of my team was because although it wasn't their formal responsibility, they used to do quite a bit of training, both on for things like vaccination and for infection prevention control. The actual answer to the question is, if you have a private provider provision, it is up to the manager of the services and the provider to ensure that adequate IPC controls are in place. And if they are accepting patients in, for example, in flu seasons and things, then I think they have that responsibility. The practical problem comes, and I'm sure many will understand this, which is if you have a fragile system of care, you then have a problem, which is if a standard or an ability is not there, you do need to look after those people. And so I think sometimes I've been in conversations where care homes are about to be closed down, and then you have to balance the risks of the care to the individuals who are losing their home effectively over what standard you're trying to implement for different parts of systematic provision. But I think the actual answer is the provider of the service, and so all services should have that, and I think the CQC should be ensuring that they do.
Well, that was my next. Who should be responsible for checking that the training is in place? That's with the CQC. May I just ask you this, though? I think there's been an acknowledgement that there is a significantly high turnover of staff in the adult social care sector, and given the high turnover, therefore a need to presumably roll out training with increasing frequency. Do you think that there needs to be any changes or amendments to the view that it should be the manager who conducts the training or is responsible for ensuring there is training, and the CQC for ensuring that the training is in place, given that high turnover?
I'd come up with a different answer, which is if you reduce your turnover, have better career pathways and proper recognition of care workers, you will retain them longer, and the education and IPC and the pride in the work that they do. I think the turnover is a problem. It's the same, actually, it's a turnover of patients in hospitals. You get risks, and this is in staff in social care settings.
May I move before we break, Miley, just to one slightly different topic, and I'd like to ask you about a SAGE Social Care Working Group paper from the 12th of May. It's at your paragraph 564 in your statement, but can I have on screen INQ 000 587-394_35. And we can see there that as at the 12th of May, the SAGE Social Care Working Group presented a care home analysis paper of the 35th meeting of SAGE, and you were at that meeting. And as at May, the minutes record that there was extensive testing of both residents and staff is crucial, both in care homes which are reported cases and those which have not. We've concentrated a lot on those that had positive outbreaks. Why was it important that SAGE was recognising the need for testing in those homes which did not have outbreaks of COVID-19?
Well, because by the 12th of May, some of the evidence now had been properly collated and come through, and it was very clear that there were significant rates of asymptomatic infection and likely transmission. Not sure quite proportionate of that, but and therefore actually testing all of these was the case. Just a couple of points. Actually, on the 12th of May, it was actually the care home working group, so this is an error on my part.
Not the social
and I
care
was
working.
not the co-chair at this point,
Right.
yes, because it changed, partly because I changed it, so we might come on to that later. But
Right.
But yes, but I think by this time, by May, because of the studies that had come through, so the Easter 6, the first tranche of the Vivaldi work, which was being reported as it was being done, then it was very clear that we needed to do that. As time went on, and when it was the Social Care Working Group and I was chairing, actually it became very evident that what we needed to be doing was testing staff regularly, and you could test patients, residents, for whom actually it was quite an invasive test with a PCR, much less frequently, and still be safe.
Can I just pause you there? So there was the initially a SAGE Care Home Working Group, as I understand it, which then became the Social Care Working Group. And you were the co-chair of which, Professor?
The latter. So I think what happened, I wasn't involved. SAGE had a number. SAGE saw the numbers rising and set up a small group, largely of modellers and data scientists, to see if they could see what was happening and look at some of the causes. That was set up under Professor Ian Hall, who I think you're speaking to later this week. And it was called the Care Home Working Group because it was just looking as a task and finish group at care home numbers. When it became obvious that there was a problem, and I was asked by Patrick Vallance to come in and chair from, I think I was asked on the 2nd of July, I came in towards the end of that month, and then I recognised this was not just a care home issue, we needed to
Wider
look
issue.
at social care, renamed it, reformed the terms of reference, and then set in some pieces
And
of
so you broadened the remit of the group.
totally to recognise this broader area of investigation.
Thank you. I diverted just to make sure we had that clear in our mind. So this is the Sage Care Home Working Group
Yes.
making this presentation, hence the focus on the care homes. Paragraph 21 there states the workforce management and behaviours are key factors in transmission. Sage reiterated the need to minimise and ideally avoid completely staff moving between homes. This presents a challenge to the operating model of many care home providers. And Professor, may I just jump forward, because we know there were many attempts throughout 2020 to either potentially bring in legislation to restrict staff movement, but generally a move towards trying to do so. And I just want to understand from your perspective as DCMO, were you asked to advise at all about how practical or otherwise it was going to be to restrict staff movement?
So that wasn't my responsibility. I mean, clearly I recognise this. I promote it, if you like, and advise as a clinical risk, but that was well recognised in the department as well. Ministers were working very hard to try and understand how they could implement something whilst keeping people safe. So on the one hand, you had a safety risk around infection, but if you can't provide a service, it's so fragile it falls over, that is a risk in the opposite direction.
Just finally dealing with the minutes of this, a little bit further down the page, paragraph 25, the Sage Care Home Working Group made reference to further targeted studies, including to understand the variation in scale of outbreaks between different care homes, and the reasons for this are needed. Was DCMO or the Office of CMO involved in any way that you can recall now in asking for further studies to be undertaken? And if so, can you remember what those studies were?
So I was aware there was work on this, and in fact, I think you heard from Professor Laura
Shalcross.
Yes. So the Vivaldi study was one of those that has come out of that, and obviously, in different capacities, I have supported and funded where we could going forward. But there were other ones. So PHE obviously did the Easter 6 study in the earlier one. There were studies in barracks.
Yes.
Which is not a care home, but it still gives a sense of trying to understand how ingress of virus is occurring.
Lady, would that be a convenient moment? For
It
the
would,
afternoon break?
certainly. I shall return at 20 past.
Thank you very much.
Ms. Carey.
Thank you, my lady. Professor, can I turn to September 2020 onwards, and a few questions, please, about that. And could we have on screen pages 40 and 41 of your statement? Thank you very much. And that's at the bottom paragraph, 5.79. You say, on the 13th of September, you advised colleagues within DHSC and Public Health England with respect to protection of care homes. You were seeking further urgent investigation, given the significant impact of the first wave and the rapid approaching winter, and what you describe as a relatively short window of opportunity to understand, take action on any risks that could be mitigated. And have I got this correctly? When we look at what you have set out in your statement, you were summarising where you were at for DHSE and PHE. So if we have a look at where you were at, and we go to the further down that paragraph, there's some italicised points. As at the 13th of September or thereabouts, there wasn't any very strong evidence that hospitals were a causative risk factor in care homes through transmission of infection via discharge policies. Upon what evidence was that assertion based, please?
So if I just go back to the Care Home Working Group and when I took over, so there was a lot of concern generally amongst clinicians, ministers about the care homes particularly and the risks. I was asked to chair the what was then the Care Home Working Group. I reviewed the group there. What I wanted to do was go back completely in an unbiased way to basics and say, hang on, there's a lot of noise about this. What do we actually know? And coming completely fresh to the evidence. So although I'd been in the SAGE group when work was presented, I hadn't been part of that. And so I had gone back and run a summit which included colleagues from right across the UK. It included virologists. It included people who'd done research in the care sector, so worked alongside care. It included people like Laura, who had been working, Shallcross, who'd been working on the first stages of the Vivaldi study, and just tried to put every head in the room, whether the work had been published or not. The easiest way to say what we knew is that the consensus statement from May 22. Now, I know this seems a long way down the line, but there is a reason for this, because actually the evidence that is in that was broadly presented in person, even though it was not yet published, at the symposium in September.
Right.
And so that statement broadly aligns with the early evidence coming through from all of the different studies across the UK, in particular things like genomic studies in East Anglia.
But this document is just designed to give an overview to DHSE and PHE of where you were at as at...
So this was not, this email, I think I'd need to go to the bottom of it, but I'm pretty sure this was not actually really trying to... I think I was a bit agitated here, actually. What I could see was some early new data coming in that said what the infection rates were in staff and residents that had just come in. And what you were starting to see was, after a lull, there was quite a steep rise. Given the information, which is broadly listed here, it's just a summary version of it. There's evidence elsewhere. This was just a summarised thing. What I actually wanted to do was say, at this particular point, we have an opportunity to look at this care worker force and say, why are the rates going up so much? But there was, as soon as, of course, they go up everywhere, then you've lost the opportunity to investigate. So I was really trying to say, is anybody working to really ask these people what they're doing, and so that we could see if there was any mitigation ahead of the winter that we hadn't thought of.
We can see there that one of the bullets points says there isn't any strong evidence that visitors are particularly high disease transmission risk, if any. And I'm going to come back to visiting in a moment, but just remember that that was in this document. You make the observation that you didn't know what the risk of transmission was for what are described as other peripatetic professionals, i.e. GPs going in and out of care homes. The association between the size of the home and the risk of the outbreak, I think we've heard evidence about that before. And can I just ask you about one of the bullet points further down the page? You say, we know there are cases and outbreaks in care homes where no visiting has been allowed in recent weeks, which still suggests that the workforce is a particular risk. And maybe we're keeping those points in mind when we look at visiting in a moment. Does it follow, though, that as at September, there is still a concern that there is a main risk of transmission was still coming from staff?
Yes, I think that was... I mean, there are different ingress routes, which I think have been identified, but all of the pointers were moving in that direction. And this is not to single out staff. It's actually because they were part of their local communities. And actually what you saw was, when the community rates rose, the staff rates rose as well. And so the trick here was to make sure not only that the care residents were protected, but the staff were protected as they came in. The really important, the reason I sent this was, you'll see in the two bullet points down from that, it said there were over 1,800 positive cases last week in care homes, compared to just over 600 the previous week. So what you were seeing was this rise. And what I wanted to do was try and see if we could stop it.
All right. I think, though, it did rise as we went through the autumn of 2020 into that winter.
This was an investigative window, though. This is why I might sound slightly agitated in the email, because I was trying to say, is anybody doing anything?
All right. Well, later that month, on the 21st of September, you called together what was called a symposium, a care symposium, which you organised as the co-chair of the SAGE Care Working Group. And what was the aim of the symposium? What was it trying to do?
This was what I'd said further. I mean, it was really, there was a very strong narrative and belief for many good reasons, which you can see without deep investigation, that discharge from hospitals was a seeding infection into care homes. What I wanted to do was just strip the whole thing away and say, let's put every single piece of evidence that we have, what evidence is growing, different types of methodologies for reviewing that, and put it all in one place. And the September or November consensus statement was the outcome from that symposium. But the May 22 one, there's a reason for why it was so late, actually says the same thing and is articulated much more. It highlights the methodological soundness of the different studies we were looking at.
Well, since you mentioned it, are you able to help us there, Professor, with why was the consensus statement that came out in 22 so late, when in fact it was based on findings from much earlier on?
So it would be a good thing to ask Professor Hall tomorrow. And there are some interesting points in this. So I come from a position where I'm an unbiased public health critical analyst, and you're looking to see what evidence is there and not be sidetracked by red herrings or pre-considerations. You absolutely need to say, what does this mean? What could it mean? 2 or 3 different things, and then follow down each path. One of the problems, I think, with the consensus statement, because it happened a little bit with the first one, was that although there was very significant consensus, there was one voice, I think, which found it quite difficult to sign up to the consensus.
Yes.
And so much of the wording, I think, looking back now and reviewing that and the one we put out, is quite carefully managed. I understand the sensitivities around that, but for me, it is really important that we look honestly at the evidence, and not because otherwise we put in the wrong protections and miss the opportunities.
Well, can I pause you there, Professor, because it may be that Mr. Hall is better placed to deal with the sensitivities and differing views about
He
the
was
consensus.
the chair in 22, I think, where I was not. Not
so
there.
perhaps we'll leave that for him
Yes.
to answer. But you set out in your statement a number of the participants, not all of the participants. Can I ask you, did anyone representing the Welsh Government or public health bodies in Wales participate in this care symposium?
Yes, I think that was not an inclusive list that's there, and there is on the 22 statement. There's some Public Health Wales evidence which was actually included then. I particularly people working on the sale data. I think I wouldn't be able to say precise names just now.
But was it a UK-wide symposium?
Yeah, it was basically anybody who'd got. It was a really wide invitation. Anybody who was working on this area, can you please come and let's share thoughts and push them around and challenge each other to see what the evidence says.
Right. We'll look at some of the key findings. Could I have on screen, please, 4074994_2, and you set out, I think there were 6 key findings. We won't perhaps go through them all.
Yep.
But 4.1, although staff-to-staff transmission has been observed to have been a contributory factor in outbreaks, it's important not to generalise to all outbreaks and emphasise one route over another without clear evidence. Studies undertaken so far indicate multiple introductions are common. Indeed, Professor Hopkins told us that, Professor Shallcross has told us that, so that's not particularly new to the inquiry now. Clusters have been observed. Many outbreaks involve cases that are spread out over a longer period, indicating multiple introductions and different lineages. And then there is the retrospective genomic analysis and seropositive studies in care homes find evidence for multiple routes of virus ingress, but again are not systematic enough to quantify the relative frequency of different routes of ingress. May I pause there, Professor? Professor Shallcross has told us that there's at least, I think it was 6 or 7 potential routes in, and it's not easy to test visitors or necessarily to test perhaps healthcare professionals coming in. But do you think from now looking back there should be more research done perhaps on the more obvious routes, namely visitors?
I mean, this to me, and in fairness, actually, NIHR funding, whether it be in social care, whether it be more in community, has tended to be focused on hospital and obvious healthcare systems, and there is a definite move now into funding research, which is much more community focused, including social care.
And just on next page, finding 4.3, the weight of evidence is stronger in some areas than others, however. evidence of staff-to-staff transmission has emerged in the genomic analysis with high confidence, but weak evidence on hospital discharge and modelling the impact of visitors does not suggest a dominant causal link to outbreaks from these sources. The weak evidence on hospital discharge, can you help us now with what research or studies that was referring to?
Yeah, and we need to don't assume that the evidence. So the evidence can be not compelling, if you like, not robust in one study, or it might be because there isn't much of it, or there's a whole load of reasons for writing weak. But what we're saying is you can't say definitively a specific number on all of this at any particular point. But actually, there were two main studies. There had been a request from the Public Accounts Committee. I think it comes through the statements more as being commissioned in November, but to be honest, that's what we were working on as well. And the approach at that point, separate from the other studies across the UK, was to look at the data in two different ways. One was to follow confirmed cases out from hospital, and that was the PHE study.
Yep.
Recognising not everybody got tested. The other one was to do it the other way round and almost look from care homes back into those who'd been in hospital. So they're two different lenses. And what you would anticipate was either they'd say much the same thing, in which you'd have confidence, they wouldn't be exactly the same, or they'd come up with startlingly different ones, in which case you'd say, what's our hypothesis here? And then you add to it, you build a picture from different studies. Now, NHSEI worked on the care home in study. It's not reported here, but it was being reported as it was done into the care group at that time on a weekly basis, as was the Vivaldi study as well. So one of the good things about that working group was we could pick up information if there was something really strong and robust, later on testing protocols, for example, it could go rapidly through to the care minister and change policy. So those were two key pieces of research. And then at that symposium, we had very strong evidence from the genomic analysis, because you need to follow the cases through and look at the lineage to see how they're related, if you like, to other cases. And then there were a number of other studies which are in the May 22 paper from Scotland, where they'd looked very specifically, they'd even gone to pulling out clinical case records, and from Northern Ireland, and then there was a paper from Wales as well.
Right. Thank you. That document can come down, but the symposium considered a number of things may contribute to future improvements, and one of those that was further research was carried on into the extent to which the physical layout of the care home influenced transmission. Do you know what research, if any, was in fact carried out on the physical estate in the care home?
So I think it would be a good question to further explore with Professor Hall, because it was actually one of the things that was picked up by the environmental group of SAGE, and he took the info, so there was a linkage through to make sure the right questions were asked. I'm not quite sure where the detail of that
All right,
is
well,
now.
we can follow that up with him. Thank you very much. Does it follow, though, from if we just stand back as at September 2020, there simply wasn't enough evidence to say which route of transmission of COVID into care homes was the most dominant? You know, there were a number of them, but not which of any of them were the most dominant.
I wouldn't say that. I think whereas you couldn't have a very precise number. I know the PHE one says 1.6%, but actually it's whatever numbers you're using, you're bound to come up with some sort of precision estimate. It's 1 to 2%. And what was interesting was when you looked at studies that had been done with different data in different UK countries, they all came up with roughly 1 to 2%. That will be an underestimate, but actually when we look at the genomic studies, I think it was around 5%. So I think somewhere, by putting all of this together, it's definitely not the dominant ingress route. The reason for, and I think there's confusion about why we're using size of outbreak, but actually there was a very, very consistent trend that when you started to do, I don't know, tell me if I'm getting lost, but you do multivariate analysis, so you're looking at lots of different characteristics of a care home or the staffing together, or you do univariate, you just look at one thing. when you put them together to adjust, all of that difference, the thing that really stands out is the size of the care home,
Right.
and then which effectively is the number of contacts, people coming in and out of the care home.
We may have been slightly at cross purposes. I think, if I understand your evidence correctly, you're saying when you look at all of the various studies that were looking at the extent to which hospital discharges were a route of ingress, they were definitely not the dominant.
Yes.
But my question to you was it possible to say, having looked at all of the studies, which was the dominant route?
So this is what I'm saying. I think you have to build a picture. This is the issue with science. You're building a picture in a different direction all the time. So I'm sure there were some cases from hospital admission in. That will depend on how good isolation control was, all sorts of things. But the dominant route from the evidence that we have is through staff.
Right. Thank you very much. May I ask you, please, briefly about designated settings? I think you deal with this at your paragraph 5.86, Professor, but clearly we know that in the winter of 2020 into 2021, there was a move towards identifying care homes that could be a designated setting to receive a COVID-positive patient being discharged from hospital. And did you have some concerns about the designated settings policy, and if so, what were they?
So it was a policy that was suggested, and on the face of it, it looks very sensible. But I always look from both sides and say, what are the benefits and what are the risks? And if you perhaps shine a different light on it to the one which is the one most people see, you start to build a picture of potential increased risk. So if I put I did support the policy in the end, but if I just put the increased risk position, so number one, because in theory, people were worried about discharge from hospitals, what you are doing is taking everybody from a hospital and putting them in one place. So in which case you might build a new hotbed of cases where they're all, if the infection control is not absolutely perfect, you will actually build a higher risk environment. Number two, the individual will, often elderly, frail, every time you move that individual, their mortality statistic goes up regardless of what's going on. So you're then moving them twice. Second point is, if you put them into that environment and then want to move them on back to their care home, they will have had 2 14-day isolation periods, so they are out of society for 2 weeks. And what you're likely to be doing then is deconditioning them for the care home, their final familiar destination, if you like, to support them. The point I make is not to say all of those are overwhelming risks, and it depends on, you do need really good infection control in that designated setting. The point is there are, as with all of COVID, there are balanced arguments and risks, and they all need to be considered.
Speaking of balances, may we turn to visiting, please? And we've looked at a number of pieces of, or little excerpts from documents which have suggested essentially there was an absence of evidence regarding the risk that visitors pose and the amount of COVID that they brought into care homes. And it's really, you set out in your statement a number of ways in which you were asked to advise about visiting. But given that absence of evidence that visitors were certainly a significant cause of infection in care homes, do you think that the balance of the visiting policies were right?
So number one, it's an absence of evidence. It's not
Fine.
evidence of absence. That is really important. Because there was a shutdown of visiting for quite a few months, as we all know, and clearly that caused concern for other reasons. But during that time, you could draw very little conclusion. We looked at this, and the second big piece of work was to actually try and do some work in the care group, which tried to assess what that risk was and then what the balance of risk was in the opposite direction, taking into account quality of life, isolation, all of those sorts of things which people have spoken very eloquently of. There is some modelling in that, and there is an email here somewhere which was very, very rough, so do not take this as evidence modelling, where we estimated how many times a visitor might come in comparison to the risk that a staff member comes in, and then try to attach a number to it to quantify. On that basis, it was an insignificant risk, but you need to bear in mind both there is a theoretical risk, and two, the data was just not available.
Given that there was an absence of evidence about the risk that a visitor might pose to bringing in COVID into a care home, do you think, when you stand back and look at it, that the trajectory of visiting guidance as it was across 2020 into 2021 and 2022 struck the right balance now? And I'm asking you, with the benefit of hindsight, I appreciate.
I think it's very difficult, because the biggest problem with care homes is when a visitor comes in, or whenever there is an intervention about stepping across the care home threshold, you are not only looking at the individual, you are looking at everybody else who is frail and living in that environment. And therefore, trying to, an individual elderly person, my father, for example, I mean, I was commissioning services for him right before the pandemic, he would have dropped all the risks and said, I just want a visitor, and I'm sure we will hear that many times. But if there is a real risk of people bringing in infection, regardless of whether we have the data, every time community rates rise. And so the trick, I think, in getting this right is to recognise that and not say it's not existent, but to say, how much are we able to tolerate? There's a societal or a care home or a family question. And then what is the balance? The thing which I've heard, but is probably not true in my experience, is that people didn't understand the real harm that can be done, and people did. And you can see that coming through the advice that was going up to ministers. And there is a quantifiable harm level, which we tried to include. But it's very difficult. At the end of the day, if you want to balance these things, it's very difficult, because it comes down to individual values, and the people we most need to understand values of are those people in care homes, and actually trying to elicit a value for them is also very difficult.
Well, if anyone would like to read more about this, at your paragraph 9.11, you make the observation that an individual's risk appetite is ultimately a personal decision. For instance, in respect of visiting, it would be quite reasonable for one individual and their family to prioritise social interaction and another to prioritise self-isolation. I'm not going to ask you about that anymore, but I would like to ask you about lateral flow tests in relation to visiting. In your paragraph 6.16, Professor, could we have on screen, please, INQ 000153358. It's an email chain, I hope. And could we go to page 2 into 3? We are jumping now to the, we can see there, late November of 2020. And Vic Rayner from the National Care Forum is writing to DHSE colleagues, and I think in due course you end up being copied in on some of this thread. But to put it in context, lateral flow tests are now available, and Vic Rayner says, morning all, apologies for emailing at the weekend. We've been informed by a member that at least 2 authorities in the north are advising homes not to use the lateral flow test for either staff, relatives or visitors, as they are not assured of the accuracy of the tests. I don't need to descend to the detail, but can you help us, Professor? Was there an issue with the accuracy of lateral flow tests?
In short, no. It's the understanding of what they were being used for. So a lateral flow, for example, is relevant for a short time period for those people who are most infectious and most likely to transmit infection. So for something like a visitor coming in, it was brilliant. It was like an open opportunity, I think. So this was actually quite sad in many ways, that people who wanted to visit, it's still an adjunct, but for a short time period. They're not perfect, as is any test, but they were a good adjunct to safe visiting. So it moved the risk dial in a more positive direction. The problem here was that as with many things, that the communication around the risks and the utilisation of them was going in different ways. And so I think when we go to the next page, probably you'll see that the people in test and trace, effectively, under Dido Harding, were rapidly, for good reasons, trying to get these out to care homes and get the logistics going. But they'd gone well ahead of assuring people like directors of public health who would understand what was happening.
All right. Well, can we just follow the email thread? It is Minister email Susan Hopkins, basically copying in the email from Vic Rayner. And if we go up, it looks like then that DHSE are preparing a response to Minister Whately. We can see there the letter from Sheffield Local Authority care homes in the area arose from their lack of information on the rollout of lateral flow devices to care homes, and asked for care homes to pause their rollout until they had further clarifications. And they'd spoken to the Director of Public Health, who concurs with the view that LFDs, in addition to PPE and IPC, where visiting is occurring, can reduce risk further. However, he wishes to be assured that the training and education of care home staff and the operational delivery of these pilots is a high standard. And we can see the response the Minister concludes: we believe the introduction of lateral flow devices for care home visitors where the visit is planned in the best interest of the resident will further reduce the risk of COVID transmission when used appropriately with other risk mitigation measures. Was there a concern that it might be either or, and people would have the test and then they wouldn't use IPC measures or PPE?
There was a lot of unhelpful media noise around LFDs. It's very difficult to control this. People are anxious. The tests need interpreting carefully, and their use case needs explaining carefully. And I think it all settled down. Of course, we all ended up using them, I think, with the recognised limitations of them. So this was a letter draft response that for Minister Whately to sign off to send out to give that assurance.
And I think you were asked, if we just follow the final page 1 of this, you were asked by Susan Hopkins to have a look at the email thread. And can you just help us with, you were saying there, I've been working with Eamon, who I think is in PHE, and Jane to urgently revise draft visiting guidance to get the right balance in wording and advice between legal rights and responsibilities, detriment from isolation, and then the introduction of visiting with LFDs, which we are all aware is an increased risk to care homes rather than a reduction. Why did you phrase it in that way, Professor?
So just to reinforce that the minute you do start opening up to further footfall, you are increasing the risk. So it's not because there was a slight anxiety that everybody would just say, oh, we've got a test here now, no problem, don't worry about the IPC, we're all safe. And of course, actually what we wanted to do was have visitors come in and still recognise that there was an increased risk if we're going in and out, theoretical, small probably, but we needed to manage that, and we needed to support those visitors to learn good IPC practice as well, because then, and they're actually very positive intervention that way because they're totally motivated on keeping their loved ones safe. So it was to flag that at the start, but then to go on. And in fact, what I was trying to do, you'll see this email, it went back to Susan, but what I was trying to do was quietly, it went to Dido Harding as well. And what I was trying to do was politely say, please can you make sure that when you're rolling out services and designing them, you link them, it's the alignment issue, back with clinicians or public health experts and people who understand what is happening on the ground. So everybody understands the purpose and ambition, the risks and limitations, and then it can all go out safely.
I don't wish to minimise it, but it's a communications issue here.
It's an alignment issue, and it's difficult because I mean, you will know I came in behind it. It's one of the motivations for going for that role was to actually try and pull it together, because both parts independently were doing fabulous things, but they weren't aligned, and it caused quite a lot of controversy.
A slightly different topic, please, and your paragraph 7.4, if it helps you, Professor, but the age-old question of data in the adult social care sector. And you say in your statement that particularly the data systems in Wales particularly were more comprehensively linked, but with a much smaller demographic, presumably because there's fewer people in Wales. Is that what you meant by
So
that?
The population in Wales is about 3 million, so it's only like a couple of counties here, if you like. You have to keep this in mind, because sometimes if you're, as I say, as a self-confessed Welsh resident now, you need to bear that in mind. Things that work in Wales will not necessarily work elsewhere. But what they have done, and for many years, they have SAIL data, and I can't remember what the acronym stands for, but effectively you are linking much more health service into community level data. And so the automatic linkage is there, and therefore exploring some of these sorts of problems is generally easier.
And do you know whether that, not necessarily the same system, but the way that the data is linked in Wales could be replicated in England, given its vastly bigger size?
So data, as we have heard, is really challenging. If we're getting on to the what would you do in the future sort of question, I'd want to be even more ambitious than that. For the reasons that we've just said, I think the care sector is under-researched. So when we get these questions, we don't know. There is a movement to move health services more into the community. And if we're going to improve health and the quality of life for individuals in an ageing demographic generally, then we should be much more ambitious on the data. So, for example, what we actually need is not just a care home link. We need care homes and GPs and hospitals and pharmacies all linked together, and local authorities, sorry, I shouldn't miss that out, so that, if you're in a, and I don't mean to position any of us, because I'm now in the aged group, as a, if let's take me as an example. If I'm now an aged person in my community and I go into hospital and get transferred to a care home and then back home, I want people to know where I am and at which point I went, because that transit point or what treatment I've had is critical to understanding where I may have acquired an infection or not, or whether a treatment has been successful. And until we get that linked, we're not going to have the answers, and we're still going to be asking the same questions.
It brings me on to your reflections and lessons learned part of your statement, Professor. And you say at your paragraph 9.2, in your view, the division of responsibility and the ownership of risks in respect of the ASC as between providers, local government and central government needs to be given proper consideration. Now, bearing in mind we can't change the entire makeup of the system, but can you just help us? Are you able to give us an example of how a better division of responsibility would help the pandemic response?
I think if the data systems were, as I've just described, it's not even just the pandemic response. I mean, if we have demands, I think we could have better health and better health outcomes, particularly for those in more deprived areas. Yeah. So there is a wider health issue here, and we shouldn't just be preparing for pandemics.
It's not that I disagree with that, but the terms of reference for this inquiry
I agree, but it will help pandemics, and it has a benefit. It does help pandemic preparedness, because if you're trying to, let's suppose we had a treatment for something, or we've got a new vaccine, they will automatically be aligned. We won't have regressed back to the position we had pre-pandemic. I think on this, there is a wider issue for me. So clearly, government it's a government decision where they put responsibility for this, but I don't think there has been adequate recognition of the private provider provision for adult social care. You can't suddenly have, in my mind, a private provision and then expect a national response unless there is something in between. So either somebody has to design something which is a national consideration, at which point everybody flips to national control, or you have a different care provision for the country. I personally, if I'm allowed, I'm in my second point, which is I firmly think that the care sector is just not recognised as an equal component of the health and care system. So that is the first thing that can be done within the Department of Health. It is now. I mean, I think huge progress has been made by the ministers, actually, and particularly Helen Whately in leading the work. She moved it right forward, and things like the capacity tracker are still operational now and has moved us a long way. But it needs equal recognition, because it will give better outcomes for people and better outcomes for health and care services.
One other matter that we have touched on in your evidence, Professor, was the difficulties in potentially restricting staff movement between care settings. And I just wondered whether you had any reflections or observations on what could practically be done to try and limit or restrict staff movement during a pandemic.
So it's very difficult, because it will still require a balance of risk to individuals. If you have no workforce to look after elderly, frail individuals, that's worse than probably than having a potential risk of infection. I go back to my first point, which is if you equalise the opportunity, the career progression, which again ministers have been doing recently, to try and improve and equalise the recognition between health and care, then some of those issues will go away.
Thank you. Well, they're all the questions I asked.
Thank you very much, Ms Carey. A few more questions. Professor, Ms Morris, who's just there.
Thank you. Good afternoon, Professor Harries. I ask questions on behalf of the COVID bereaved Families for Justice UK. And a few short topics, please. First of all, I want to ask you a bit more about preparedness. At the beginning of your evidence, may feel like a long time ago, Ms Carey asked you about early response plannings, and in particular a meeting on the 11th of February 2020. It's not going to be a memory test. I appreciate you may not have a direct memory of it, but you did say in your statement that the meeting slides from that meeting said that social care will need central oversight that covers local authority and private providers. So my question is, do you agree that as of February 2020, and even before the emergence of COVID-19, there was no plan in place to ensure that effective oversight and support to the sector?
I don't think that's quite the same thing. So I think, first of all, the comments are actually what came out of the meeting. They weren't mine, just for clarity. I think they were coming from the meeting. I think what that was saying was that was a mechanism that needed to be focused on. My comments earlier about the recognised provision of care in the country is one where there needs to be some sort of systematic oversight. There was a system. It predominantly came, if you're looking from a central government position, it would be local authorities who contract with those providers, and then MHCLG who oversee that area of work. But I think there's opportunity to improve it by some substantial way.
Thank you. My second topic, planning for safe discharge from hospital, and moving forward in time from the 11th of February. I think after that meeting, you were sent a follow-up email about some actions that were allocated to you, namely to draft clinical guidance on a response to COVID in care homes. And there was an email exchange that you've looked at already with Ms Carey, the Valentine's Day emails. I think Professor Willett was one of the recipients of that. But in your initial reply on the 12th of February, you said that there was two elements to the task that you've been given. The first was about containment, the containment phase of handling of cases within social care. And secondly, managing large numbers of patients in the face of an epidemic. And you said that that second part in particular would include decanting as clinically safely as possible large numbers of patients from the wards to the community and social care sector, and then potentially onwards. So it's that decanting which envisages discharge from hospital. You said in those emails that those two tasks should run in parallel, and you raised the issue of decanting patients in subsequent emails to Professor Willett at the NHSE. So despite this very early consideration by you of the importance of clinically safely decanting patients from hospital, you say that you didn't then have any significant input into the 19th of March discharge requirement. So I kind of want to explore with you what you did do, having been tasked with it and identifying those two work streams in parallel. What did you do between February and March to look at that hospital discharge?
So I think, I haven't got the paper up on screen, but I think the one thing I was specifically charged with was the management of the case, if you like, and that actually belonged to PHE, so that should not have been tasked to me, and I think you can see that back, and in fact that's what PHE did. The second one was I wrote to Keith Willett. So the DCMO role does not do things usually. This was actually inappropriate tasking because usually some other operational part of the system will do, and then I will comment or challenge on behalf of ministers.
I see.
So the first one was PHE did it, and I linked with them. The second one was that email, and I linked with Keith Willett. And you will see through many of the things we've discussed, what I was trying to do, although I'm not operational, was trying to make sure the things, as the work was progressing, there was alignment. And ministers also were doing that, because you can see on that 6th of March meeting, which the Secretary of State called, was trying to, I think NHSE were in that meeting as well, was trying to make sure all these moving parts were moving together.
So given your role in that February and March period, would you have been expected to have been consulted in any way about the impact on the adult social care sector by the discharge policy?
Not specific. Normally, well, actually, at that stage, this was pre-triple lock. I would not necessarily see guidance. It depended on whether people who were developing. Normally, if you were developing policy in slower time, you would expect something to come up to CMO's office for a view, or sometimes an early meeting to set a direction. But in this case, we're in the middle of we've got a pandemic brewing, and so I would not normally. Some of the guidance, as we've seen, came across my desk. Many of the final copies, I was not in the final emails too, and that's how it worked until we got to around the 21st of May when a triple lock came in.
All right. Moving then to the admissions advice, so the 2nd of April, and that guidance. I just want to clarify with you, if I may, some of the evidence you've given in response to Ms Carey's questions, and in respect of isolation in particular. Are you saying that if it is obvious that anyone discharged from hospital, whether positive, negative test or untested, should be isolated? Have I understood that?
No, that's not what I think. The comments that I sent back, the Minister raised some very sensible questions and was quite persistent in the email exchanges that were coming back, and she would often copy me in to get my view as well. So the question she was particularly concerned about was a discharge of a COVID positive patient into a care home, and whether this was a reasonable thing to do, and whether it was safe to do it. And so my responses on those was to flag that I expected a risk assessment to be done by the local care home, a receiving home, and that there were adequate isolation facilities. Now, as long as there are, then it is a reasonable thing to do. And the debate about the 7 and 14 days was actually to extend the normal period of isolation to make sure that the frailty of people in that environment was recognised.
I understand that, but in your statement you say that onward isolation was of more importance in transmission control than a single negative test.
Yes.
You've explained the limitations
Yes.
of negative tests. And you said that the strongest mitigation was a robust isolation period, regardless of whether the patient or resident had tested negative or positive at the point of discharge.
Yes.
So I'm asking whether we can infer from that your advice was isolation is the key measure,
So I think
irrespective of
that
testing.
I know everybody's got very hung up on testing. I mean, importantly, there was not enough testing, and that was not the main prevention. It comes back then to a more general issue, which is what was the probability or likelihood of an individual having COVID when they left, and what was the balance of risk. So I think one of the things we haven't discussed here is if, for example, you put in a policy that says every individual who leaves hospital is going to go into 14 days isolation, even if they are unbelievably well and ready to go. They need to come out of hospital because actually they're sitting in the path of a pandemic and they're likely to decondition. The question then is, given all the comments we've just had about visiting, do you want to put somebody in 14 days isolation when they have no symptoms and are otherwise well, and we know it will be harmful in other ways to their health? And that is we're back to this balance question of what is the right thing to do. And that right thing to do starts to change when the evidence around asymptomatic infection starts, and then the important one, the asymptomatic transmission, and they are not the same thing. Somebody who is asymptomatically infected but not transmitting infection is not going to be a risk to others. Somebody, once you have discovered a high proportion of asymptomatic transmission, then the policy changes. I have actually, it's quite interesting because I have looked at international comparators on this, and one, for example, which I was quite surprised at, was Singapore, because I was trying to see where were we in the asymptomatic infection transmission line, and actually they didn't change their policy till the month after the UK changed theirs on hospital transmission.
So we're talking about 2nd of April guidance.
Yes.
In my question.
Yeah. I'm saying Singapore changed theirs in May, I think.
Understood. Okay. My last topic is around data. You've given your reflections already about how data can be better utilised going forward. But I just wanted to ask you this as the then co-chair of the SAGE Social Care Working Group. In his statement, Alistair Donaldson, who was working with the Vivaldi study, tells the chair that he, quote, repeatedly witnessed how relevant members of PHE and SAGE, who had overseen and failed to warn against or properly mitigate the tragic initial errors, consistently used inadequate methods and extremely faulty data, which played down the seriousness of the problem in care homes. What's your response to that?
I don't remember Mr. Donaldson from this, and clearly the lead investigator was Professor Shellcross for Vivaldi, who came and gave evidence, I think, in the last couple of days. I think from the statement, Mr. Donaldson himself says he has no background. I think he has a history background. There is no science, epidemiology or data background. And I think that is important because understanding the methodology behind these, things like confidence intervals around outcomes and the problems with data are absolutely critical to understanding the validity of research. And all of the data issues, there are numerous data issues, they are all outlined in particularly well. They were alluded to in the early 20 consensus statement. They are very clearly outlined in the May 22 statement. They were all known, and that's why there were two studies looking in different directions and why we don't use one study alone. What we're looking at is information which is either diverging, evidence which either starts to diverge or connects together. And in this case, we've got about 7 different pieces of information studies which start moving in the right direction, all in the same direction. And so all of there are big problems with the data. They're all outlined and they're all taken into account.
Thank you. Thank you, my lady.
Thank you, Ms Morris. Mr Straw, I think, yeah, Mr Straw's over there.
Good afternoon, Professor. I represent John's Campaign, the Patients Association and Care Rights UK. At paragraphs 5.7 and 5.36 of your statement, you draw attention to the fact that many of those who draw on care outside care homes receive it from family or community carers. And you note that this support is vital and that you cannot safely isolate someone who needs assistance with their activities of daily living. In your view, did the government sufficiently understand the vital importance of this support, particularly early in the pandemic?
Yes, I think so. In many areas of pandemic response, not everything will be written down. I mean, this is slightly problematic. It doesn't mean it wasn't recognised. And it also doesn't mean there's an easy answer to it. And I think when guidance was created, I've seen some of the comments back. I think one from Age UK in one of the statements, for example, which says, almost says, well, does government not realise you can't give care in a 15-minute patch, for example? But I think this is an interpretation issue. So what you want to do is try and minimise risk whilst recognising that some risk is actually not able to be taken away completely. And clearly, if you have people who on a daily basis need support with their daily living, then you have to have prolonged close contact and you need to make that as safe as possible.
There's a linked question. In the paragraph 5.36, you discuss dementia wards and note that there, personal contact is essential, well-being and demise are imminent without it. A number of stakeholders consider that often during the pandemic, COVID infection control was prioritised and the need for this essential care for people with dementia and similar people was given insufficient weight. Would you agree with that?
No, but I do. I think what we saw throughout the pandemic, people understood that. You'll have seen from many of the statements that have been exhibited today, certainly I was making those comments, and I know many are equally, if not more, able to do that in different parts of particularly Public Health England at the time. The difficulty is, what do you do and where do you draw the balance? Because we've also noted that individuals with dementia had a higher mortality rate, and that's almost inevitably linked to the fact that they may well not be able to understand or implement control measures as well, that their life might be more chaotic, if you like, in some ways when you're trying to control for infectious disease. And so the balance goes back to this point, whether it be visiting or whether it be infection control, that then becomes an issue of where does the risk line need to be drawn. So I don't think it's a lack of recognition. I think it's a lack of a not very easy answer.
Later in your statement at paragraph 5.69, you explain that you gave advice that risk assessments should occur to determine visits policy and perhaps to try to find that not very easy answer in specific settings. And you note that some residents' lives would be at risk for reasons other than COVID-19. Firstly, are you aware that in the first wave in England, that the majority of residents in care homes' deaths were caused by non-COVID causes?
I don't think I could. I think we need to specify that much more carefully before I could agree with that, because as we've heard on lots of the data issues, there were excess deaths in the first wave. Some of that is still not entirely clear. There are direct deaths, there are indirect deaths. So I think that's quite. I wouldn't concede, if you like, to that particular statement. I think it's much more nuanced than that. The point I think that you're drawing the fact to is, and I have acknowledged, is there is a risk of mortality and morbidity alongside a pure risk of infection and infectious disease. And again, the problem with care homes is that risk pertains to not just the individual that's being considered by their family or their visitors, but actually the transfer of that risk onto a whole care home of residents. Again, so I'm very empathetic, as I think you can see, to the risks and aware of them. Trying to draw that line is more of a societal or individual care home issue. I think also what happened, I mean, a couple of things that need recognising. Number one, I don't think there was ever any legal denial, if you like, of visiting. I think this is quite important. So I know in one of the studies, I think something like 93% of care homes had stopped their visiting by the 23rd of March, if I remember. That wasn't on an edict that came out from government. And I know many care homes were very worried, which I understand as well, about things like their insurance and trying to have some sort of backstop, if you like, some sort of delineation between where you should veer on one side of infection safety and where you should veer on the other side. And so if somebody was at the end of life or at risk of life, which I think is where you're going, then there was always a recognition, I think, in each of the guidance documents that went out, how it was implemented and the difficulties of that for individual providers is quite tricky.
Going back to your recommendations for site-specific risk assessments, there's evidence that they were often not carried out. Are you aware of that? And can you give any views on what more could have been done to ensure that they were carried out?
Is this risk assessment for visiting?
Yes.
Yeah, I mean, again, this is a whole. You cannot have a blanket statement from a national level. Or to my mind, I'll rephrase that. I'm now an individual, not a representative of government. You cannot have a blanket statement that goes out that says, absolutely, this is what's going to happen in every single care home across the country for all of the reasons which you've just said, because you will have mixed populations of residents with different risks and different needs. And the only way to do that, it's the same in some ways as the infection control in hospitals, because in the background you will have different epidemiology with very high rates at some points in the pandemic of infection in some areas and almost nothing in another, and those risk profiles are different. So I would not know, in all of the thousands of care homes, when I was sitting in the Department of Health, how many or not care homes had done formal risk assessments. I do know that what we tried to do was get a system where which Directors of Public Health could almost help with, because they would have a sense from local authorities how robust the care home provision was. So things like how good was their infection control usually, if you like. But they'd also have an understanding of the epidemiology as well. And then the care home itself would have a very good idea, one would hope, with relatives, of the individual risks attached to an individual resident. But it's none of these are easy answers, which I think is what's clearly established.
Okay, slightly different topic. You explain later at paragraph 5.74 that in July 2020 you asked the Social Care Working Group to examine whether balanced guidance could be produced, which specifically included wider exploration of quality of life considerations. Now, firstly, by wider exploration, do you mean the adverse impact of the restrictions themselves, for example, non-COVID deaths, non-COVID illness, and so on?
No, more on an individual. So this was saying, as you've just described, if you had any individual resident, they would be at risk of infection, but they would equally, to different degrees, depending on their underlying health status, physical status, conditioning, be at risk from deterioration for other reasons. So, for example, an individual who will not eat unless they have an assured member of their family with them is at immediate significant risk if they are not maintaining an adequate dietary intake. What we were trying to do, though, there was a holistic well-being issue. What I had heard from the ground upwards was that care homes particularly were concerned about insurance. I'm not saying they weren't, clearly were concerned about their residents, but that seemed to be quite a negative angle on whether they felt able to open up a little bit more to visiting. So what we tried to do was say, OK, if we could produce some, what might look like quite scientific evidence, but some really strong evidence that highlighted where the balance of risk was, that then care home managers would feel comfortable to use that to open up their visiting proportionately. The difficulty we found, and you'll see it when it comes around to that November guidance, was we had all sorts of people in the room who have worked on quality of life in care homes with elderly residents, was this issue of, for every kind of expression of it, you need a value to be derived from the individuals themselves, and that's incredibly difficult from somebody with dementia anyway, and really difficult in the middle of a pandemic. Now, the work which I think Professor Hopkins referenced around the ASCOT study, so using an adult social care outcome tool, starts to try and address some of those issues when we do not have a pandemic raging, so that we can perhaps develop better balanced guidance for the future.
I think that's my 10 minutes.
Thank you,
very
Mr. Straw. Just a last few questions from Ms. Beattie, who's over there.
Thank you, Professor Harries. I ask questions on behalf of disabled people's organisations. On the 5th of March 2020, you attended a social care coronavirus meeting with the Minister of State for Care, Helen Whately, and senior department officials. And just to be clear and to avoid any confusion, this is not the 6th of March meeting which Ms Carey took you to, but the day before, the 5th of March. It's also not a memory test, so I'll proceed with the questions, but if the document could just be brought up to assist Professor Harries, it's 595303. And this meeting considered local authority planning. At that time, the Minister for Care expressed concern about the only two plans she'd seen. A process was still being set up to assure local authority plans. And the second last bullet point on that page shows that you had a call lined up locally to get some soft intelligence on plans. So what soft intelligence did you get on local authority plans?
Rather predictably, from memory, and I think it also was where the SRG, the SCG coordinating group information came back, which was this was variable. There were plans, because I think in this one I did give some assurance that for individual care homes there are sometimes very detailed plans, because if care homes have had a flu outbreak, for example, they will be working with local systems and have some very detailed knowledge. But at this sort of level, trying to get plans for every care home right across the system and pull it into an LRF, as the Minister found, it was, many were absent, and the quality, I think, was variable as well. So in theory, there should be plans there. In practice, it's not as immediately available, if you like, for the pandemic as as it was.
So, Professor Harries, I think your answer is referring to detailed plans at an individual care home level rather than a local authority level. Is that right?
Yes. So I think in the bullet above that it says there are hugely detailed plans sitting at local levels that may not surface. So as in there is some information there, but if you send a message out from the LRF, you might not find it all. But equally, I think what Minister Whately found was, which was part of the problem, actually there weren't plans sitting above that. And I think this comes back to, at the end of the day, there is a care home provision in an LRF area is still a private business. I mean, I was trying to think through how this related. So, for example, I know this is slightly diverging, but just an example, if you will indulge me, there are risks, for example, around meat producers, cold meat producers. We do not go to private businesses generally and expect them to have plans. They have plans for some safety issues. The issue here is if you have a private provision model where the responsibility is sitting in normal times with that provider, it won't always be available to an LRF, and it won't almost be known.
Well, Professor Harris, I think there was responsibility sitting at local authority level, not just at individual care home level, and obviously an individual care home plan wouldn't be of any use for covering domiciliary care, for example, would it?
Well, it depends on what the type of provider was. If they were contracted to provide domiciliary care, then it would be.
Did you ever see a domiciliary care
Well, I
plan?
would not be operating at this individual. I have seen them historically when I've worked in local authorities, but not in my recent role, no.
So is the sort of upshot that you didn't get any assurance about the existence and adequacy of plans either at
So
local
this wasn't
authority
my
level?
ask. This was for the minister to get assurance, and for me then would have been, had I seen some plans, she may have asked me how adequate those plans were in relation to public health or risk prevention.
But sorry, from the call that you had to get some soft intelligence, is the upshot that the intelligence you got was either no plans or not adequate?
So the call was, I was having general calls with directors of public health to understand what it felt like on the ground, to see whether the plans were available and whether they were coming forward. And so the answer, as I started with, was there's a variable response. In some areas it would be quite good, in others there would be very little.
And I think
Inconsistent.
in your statement, you said, in any event, the majority focus of the 2018 pandemic plans was theoretical rather than practically exercised. Is that right?
I think that is a fair comment, for which we've heard in earlier modules, which is you do need plans and they need to be ready to respond, and you don't necessarily need one that is this pathogen specific because you don't have the response. But actually having something which nobody has exercised. So I would doubt that many care homes across the country, even if they have their own plans, have actually exercised them.
So given that was your view of those 2018 plans and what you learned of the plans from the soft intelligence call, was it not misguided, in your view, to be relying on them at all for the COVID response?
Well, I think the minister didn't. That was what they, particularly, and the Secretary of State, but that's exactly what was coming out of this meeting. And the meeting on the 6th of March was actually looking at these. That was felt to be not adequate for where we needed to go. And so that is why the Secretary of State and Minister called the meeting on the 6th of March to actually move the thing forward. And if the plans weren't there, then actually we needed a different approach. So that's why they then moved to the meeting the next day.
Right, and so I think we'd seen in the COVID plan that had been published already by then that a reassurance that LRFs had plans, and that was what was being relied on. But when we get to the action plan for adult social care, which was published on the 15th of April, we don't see any reference to local authority plans. So does that reflect what you've just told us, that they're in a sense abandoned for these?
Well, again, I need to be very clear what my role is. I would advise on things if asked. So the adult social care plan is probably one to ask of Minister Whately or members from Department of Health. But I think, as you have identified, that actually the Minister and the Secretary of State called the meeting the next day, partly because actually they weren't comfortable and they did not feel fully assured, and they wanted to make sure that there was action. That's why they put in the meeting the next day.
Moving to visiting, you've been asked already some questions about what was happening in July 2020 and that you asked the working group to begin work then to see if a balanced approach to guidance could be produced, which explored wider quality of life considerations. How, at any time, did the Home's visiting guidance take into account that reasonable adjustments were needed so that disabled people, including people with learning disabilities, people who have hearing impairments, are deaf, those who use British Sign Language as their first language or have visual impairments, could have equal access and contact with their families and friends and external carers?
So it's probably a question that you should probably have directed to Professor Hopkins this morning, because, again, without trying to appear not responsible, it wasn't my area of responsibility. I do know, obviously, from previous roles that the guidance in terms of trying to, it was produced in different scripts and what have you. There's an access issue to information generally. And there is always in guidance a clause that seems to my mind perhaps to have been misinterpreted, which is if it is essential for visiting, there has never been a block to visiting. There is a balanced risk about it, which has to be taken into account. But government did not sit at the top and say nobody can visit somebody who is disabled or what have you. The issue is about getting the balance of that right. And so I don't think any of the guidance, which again was not my personal responsibility, actually absolutely forbids. There is no legal reason for people not to
Do you accept,
to visit.
Professor Harries, there's a difference between absolutely forbidding and actually setting out what steps might be needed, and also that I think in your previous evidence you were explaining that a lot of these decisions about visiting come back, I think you said, to individual values, risk appetite, which being ultimately a personal decision, and that it's difficult to try to elicit a value for those things. But would you accept that some of these are very objective, very real barriers which don't need any eliciting of personal values?
Well, I think
to
two things, which I feel as though we're perhaps going over the same ground, so my apologies, but I'll just say two things. So, number one, the work that I tried to do in the Care Working Group was completely novel and was proactive on my part to try and get some sort of framework around this for guidance going forward that actually worked for guidance, but actually worked for those supporting individuals, whether it be in domiciliary or whether it be in care homes. So that's the first one, because that has not been produced before and it was extremely difficult. We broadly had to stop trying to do it at that time, and then it's now being taken forward as a long-term issue, a long-term programme. And then the point which I made earlier, which is around individual local assessment, you could not possibly write at national level a whole list of things which would work for every single person across the country. It just doesn't work, and hence my point of reinforcing that the guidance that is there does say, I'm pretty confident that if it is a detrimental issue, if you like, of significance, then visiting should be allowed. I cannot control, and neither could anybody at national level, precisely what was happening in each care home or each service across the country. I think probably where we would very clearly align is to try and improve that going forward, and my approach to that was to try and establish some sort of evidence framework which allowed people locally to be confident in the decisions, balanced decisions about opening up and risk to visiting.
Thank you very much, Ms Beattie. I'm fairly confident, Professor, that completes the demands that we'll be making on you personally. I think we're probably making demands on the departments for which you work again, but I think that's the end for you. And thank you very much indeed for all your help to the inquiry. I appreciate we've called on you how many times now?
Quite a lot. I think every module but one.
Anyway, I wish you a long and happy retirement.
Thank you.
Very well, I shall return for 10 o'clock tomorrow.
All rise.